Thank you, Dr. Shetty, for inviting me to talk on traumatized eye and ultrasound. And this is the topic of my presentation. So these are my financial disclosures. I have no financial interest in this talk and in this presentation. You can ask me a very simple and logical question, that why would you like to do an ecography in a traumatized eye? The answer is also very simple. In a traumatized eye, when the patient comes to the OPD or your clinic or in your practice, it is very difficult to examine the patient because of the severe lid edema he is carrying, chemosis of the eye, and the patient is definitely symptomatic. So he or she is experiencing pain. More so ever, there is opacification of anterior chamber. The lens may be opacified. He or she may be harboring a traumatic cataract, and this might hinder a good examination of the retina and the optic nerve head and the periphery, and also you cannot give a diagnosis or prognosis of the patient. So here is the role of ultrasound, and it becomes valuable and essential. So definitely in traumatized patients, whether it's a perforating injury or a blunt trauma, you ought to subject the patient to ultrasonography. The procedure already my revered speaker already has discussed earlier in the earlier lecture, but definitely in short, it is definitely done over the lids because the patient might be having an injury, might be harboring an open globe injury or a closed globe injury. In open globe injury, you never do an ultrasonography at the time of the injury. So it is definitely done after primary open globe injury repair, whether it is a corneal repair or whether it's a scleral repair. And definitely if it is very urgent, or if the patient is harboring an intraocular foreign body and you think that you ought to subject the patient to a more vigorous procedure, then you can do a very gentle ultrasonography if it is very essential and unavoidable. Now, screening and the examination protocols are definitely the same as my earlier speakers have told. So in my subsequent slides, I would be talking with examples which I have come across in my practice in the OPD, how I examine a patient of a traumatized eye. So let us look at this 26 years old male who had 4 days history of trauma with a wooden stick, and we did an ultrasonography and we related the clinical findings with the ultrasound. Mind it, you have to relate clinical findings with your ultrasonography. So if you see a hypopyon and you do ultrasonography, there is a total opacified vitreous. So this is definitely multiple medium reflective opacities in the vitreous, and if you correlate the clinical findings, and this is a vitreous mode, because that is the area which you would be seeing concentrating, the patient is having an endophthalmitis because of the trauma. This is another patient. Look at this. This is an opacified vitreous. A 6 years old male had a trauma by a wooden stick. So these are the pictures clinically, and this is totally opacified vitreous, and this is the vitreous mode at a very high gain setting. So you are basically dealing with the patient who you have to subject the patient to a surgery, and we did a surgery for that, and that is the result, a totally eco-free vitreous cavity. Another patient of a trauma after a cracker injury came to the hospital. The eye had proptosis, severe restriction of movements, and the patient was in pain. We did ultrasonography, and that is in the choroid mode, because that is the place you would be seeing in the area of the choroid, below the choroid, and that is the typical fluid, and that is a T sign, you may say, that's a half T sign, and fluid in the subtenon space. So the patient is having panophthalmitis, and also there's opacification of the vitreous, so vitreous is also clouded and inflamed. So this patient needs intensive treatment, maybe medical, maybe surgical, but definitely an intensive medical therapy. So another patient, 24 years, male, hammering a rod, that was his occupation, came to us with an open globe injury, and we repaired it, and we did an ultrasonography. We found that there's a hyperreflective echo in the area of the lens, and that was an intralenticular foreign body. This is another picture of a guy who was 30 years old and was hammering an iron rod, And what we did in ultrasonography, because there was a cataract, so definitely ultrasonography was needed, and that was a hyperreflective shadow with a caustic shadowing behind. So that is a total ecolucent area behind this shadow, behind this hyperechoic lesion. So that means the patient was harboring an intraocular foreign body, and the gain was also less, that is 55. That means this echo is definitely of foreign body. Another patient, 24 years female, had an injury with a vegetative matter in the forest. She had gone to cut wood, and that is the clinical picture. Total opacified cornea, hypopion there. You can't see the retina, you can't see the vitreous. So what we did is ultrasonography. You could find a membrane-like lesion, multiple reflective, eco-reflective opacities, and this is a lesion which is very hyperreflective, projecting inside the vitreous cavity from a corner of an area, and definitely behind that you can see this acoustic shadowing, suggestive that the patient had an intraocular thorn gone inside while she had gone to cut the wood. Another patient, an engineer, came to us in the clinic. We did an ultrasonography, and that's a clinical picture, repaired eye, and that's an hypopion. We did an ultrasonography, and that is in the vitreous mode. We found that there's a hyperreflective area which was definitely a foreign body, and this area of the vitreous was totally opacified and was echogenic. Normally it's not echogenic. So that means the patient was having foreign body with endophthalmitis and needed immediate surgical intervention. Another patient had a similar pathology, opacified vitreous and a foreign body at low gain, also a patient with an injury by a stone. Now let us look at the example with vitreous hemorrhage and intraocular foreign body. So this was a 25 years old male, was a bystander when people were hammering iron rod. So what happened is that the metal flew and hit his eye and went inside, and that's the clinical picture. You don't see anything behind the lens, and that is an area which is totally echogenic. And another area which is showing a very hyperreflective echo, giving a very hyperreflective echo at a very low gain, thus suggesting that the patient was having a vitreous hemorrhage with an intraocular foreign body. So that means the patient needed intervention immediately, because that is the foreign body inside the eye needs immediate surgical intervention. So this is another patient, had an intraocular foreign body, came to us. Foreign body was removed, and later on he developed this hyperreflective area, which was a hyperreflective lesion, membranous lesion, which was attached to the disc, and it was very taut, and that means the patient was having a detachment of the retina after intraocular foreign body. So another patient, 35 years old female, came to us with trauma with a wooden stick, had a glaucoma surgery, and already Dr. Shetty has mentioned that's a dome-shaped elevation with a hyperreflective areas in the dome shape. And if you correlate clinically and look at the picture, definitely we are dealing at the low gain setting in the choroid, definitely choroidal detachment and a hemorrhage. That is a suprachoroidal bleed which is occurred in the retina, in the choroid, and that is the choroidal hemorrhage before the drainage. And we put the patient on steroids and antibiotics and cycloplegics, that is atropine, and finally after drainage, this is the result. The dome-shaped elevation is gone. Another patient, a similar picture at low gain of the choroid, and you can see that this is a typical dome-shaped elevation in the choroidal mode, and that's a suprachoroidal hemorrhage. So trauma can also cause many changes in the eye, and this is a 45 years old blunt trauma patient with a stick, a very common injury in the part where I'm doing my retina surgery. And this is a typical lenticular shaped structure, and that was after trauma, so the lens has gone and dislocated in the vitreous cavity after the trauma. Another picture showing a saucer-shaped lesion, and that's a typical saucer-shaped lesion in a 65 years old female who became aphakic after a blunt trauma. We did an ultrasound that was just for academic reasons, and we find that this is definitely intraocular lens which has gone inside the vitreous cavity. So another picture showing a detachment of the retina and intraocular lens and that's a detachment which is definitely giant retinal tear. Another patient, 42 years male with a defective vision after a traffic accident, and that definitely you can see the vitreous hemorrhage, and all these echoes are there suggestive of vitreous hemorrhage after a traffic accident, and the patient needs an intervention. Another patient with a PVD with a vitreous hemorrhage, you can, on a kinetic echography, which cannot be shown here because I don't have a video right now, you can see that this area moves, the total opacity moves on the movement of the eye, suggestive that the patient is having traumatic vitreous hemorrhage with PVD. So this is a patient who had trauma by iron rod, and definitely you can see this hyperreflective area and the receding of the optic nerve head shadow. That means the patient was receding of the optic nerve shadow, means that the patient had an avulsion of the optic nerve head, and on history he had no PL. That means we were dealing definitely with an optic nerve head avulsion. And finally, this is a borrowed slide from the Green's Atlas, and that shows an area which was very hyperreflective after a trauma, and definitely a membranous lesion and a hypoechoic lesion in the area of the orbit, showing that there is a vitreous incarceration, detachment of the retina, irregular contour of the eye, and thickening of the sclera. That means the patient had a posterior scleral rupture. And this is a picture which shows that you can't appreciate the entire globe. That means the globe has been disorganized after a cracker injury and after a scleral tear repair the next day when we did an ultrasonography. So what is the conclusion? Ultrasonography in traumatized eye helps in diagnosis, better management, and is also a useful tool in prognosticating the patient about injury. Thank you very much.